PDMPs-Role National Medicines Policies. Moderated by Tomasz Kluszczyński, Director of ACESO Healthcare Consulting. Our speakers are Dr. Tobias Volkwein, Partner at D+B Lawyers. Deputy Minister Jakub Dvořáček from the Ministry of Health for the Czech Republic. Adrian Goretzki from the Healthcare Education Institute. Kostera-Pruszczyk, Professor of Neurology and Pediatric Neurologist from the Medical University of Warsaw. And Natalia Bartosik, Global Value and Access Lead from Takeda.
Good afternoon, everyone. It gives me a tremendous pleasure and honor yet again at IPPC to be hosting and moderating the very last panel, hopefully also bringing some of the summaries from the last 2 days. We have a tremendous discussion panel today of representing all of the stakeholders who are involved with PDMPs, with patients. They were already introduced, so that saves me a little bit of time for a presentation and discussion. There it is. We'll start today's session with a very brief presentation, and then we'll open the panel to a discussion. And I think in the spirit of equity, and the title of this panel is Equitable Access to Self-Efficacious PDMPs. I think in the spirit of equity, we want the equity to be shared by all of us, meaning that if you in the audience have an urgent question, please raise your hands. Let's not just leave it to the very end when we may be running out of time, because if there's something extremely critical and important to know, and to any of the panelists, please ask those questions as we go along. So that's the equity on your part. But on the other side, of course, equity is a term that is so often misused or misunderstood. So what we try to do, and you will see that very shortly in the presentation, is to not only look at how countries and whole continents like EU can promote equity, but more importantly, what are the barriers to equity at the national level, and what are the sources of inequity that we must mitigate or de-risk. So let me just quickly go to the presentation. Well, as I mentioned, we have identified, together with the PPTA and with many of you out there who contributed to this research, multiple dimensions that potentially provide barriers to the access to safe and efficacious PDMPs. One of those barriers is cost containment measures that exist in Europe. We have been, over the past 2 days, discussing how fragile is the value chain, the ecosystem of PDMPs, especially those that are in the biggest demand and the shortest supply, like immunoglobulins. Then what we looked into is, at national level, to what extent this fragility is made even more risky, even more pressurized. So what we are seeing with cost containment is a twofold picture. There are many countries that do not make any special allowances for PDMPs and apply cost containment measures as if they were any other type of treatment, like generics, small molecules, biosimilars, etc. And that means it's a rather punitive way of looking at a supply of this extremely valuable resource. So there are countries that apply clawbacks either based on revenue or market share, meaning what is penalized is growing revenue or growing market share. There might be a clawback that means paying back to the payer, to the government, based on budget cap. And it can take different forms. The budget can be pre-agreed with the producer, or the budget can be superimposed by the policymaker or a payer. And again, the payback is back to that payer. And finally, there are other cost containment measures such as excessive price procedure. And I think I want to stop here for a moment, because the second slide will actually speak about pricing in greater detail. The excessive price procedure can be particularly damaging to the industry when countries are referencing each other, and it starts sort of a race to the bottom of the price, which may not be appropriate, especially, again, I will reinforce the fragility of the ecosystem. So what on this slide is very important to remember is not the countries that do things wrongly, which there's plenty wrong, especially when we are not making a special protocol for PDMPs, but rather also to look at countries that decided that PDMPs are so unique that they need to be exempt from those punitive measures. So I think those countries are really showing us the way that there are solutions by, for instance, exempting PDMPs from avec clawback or excessive price procedure or any other measure that would potentially limit access to them. Countries like Romania that a few years ago started a temporary exemption for vaccines and PDMPs now introduced a permanent one, learning that actually it is the right measure to improve access. And so on and so forth. There's probably plenty of detail to be had, but this research will eventually be published as a paper, so please look out for that. Now, I already adumbrated that there is also the excessive price procedure, and there's another aspect that potentially I'm using the word punitive quite freely here, but they can actually pressurize the already low margin industry, meaning how the prices are set at the beginning, but also more importantly, how prices are revised on an annual or biannual basis. And many countries in Europe applies either ERP, which is external reference pricing, or IRP, which is internal reference pricing, or both. It's sort of more or less seemingly equitable if they look at average European price to benchmark themselves against. But as I mentioned, this race to the bottom is really where we have external and internal reference pricing taking the lowest price in Europe. You can only imagine that if on an annual basis, immunoglobulins or PDMPs at large are always referenced against the lowest price, the price will continue eroding pretty much indefinitely, and that's not sustainable for obvious reasons. That's not sustainable because of the nature of the industry, but it's not sustainable for any industry. We have seen many generic houses also struggling with that race to the bottom, and we definitely do not want that to be repeated for PDMPs. And I think, again, like with the previous picture, this picture showcases also countries that do not look at ERP or IRP for PDMPs, allow some sort of more value-based pricing, value-based reassessments for PDMPs, sometimes actually leading to price increases. If I'm not mistaken, in Poland over the past few years, the prices for PDMPs instead of falling have actually increased moderately, modestly. Now, beyond that, I think in the spirit of equity, as I mentioned, I would like to also invite maybe Natalia Bartosik, who represents the industry on our panel from Takeda, to maybe comment on those two elements, because they are often misunderstood, and the gravity and the damaging nature can be misunderstood. If you can maybe give us a little bit more of a perspective on the cost containment from the perspective of the industry, and on the repricing or pricing from the perspective of the industry.
Thank you, Tomasz. Yes, I cannot agree more to what you have already signaled here. I think that if we have looked at this slide and the other slide about cost containment, we would not be able to find a single country in Europe that is actually completely exempting PDMPs from cost containment, and this has repercussions for the whole plasma industry. As you said, there is the prevalence of IRP. Only 2 countries in Europe do not have IRP at launch, and that IRP, meaning external price referencing, this is applied at launch, this is applied post-launch, with some time interval, maybe each year, maybe each 3 years, and so on. There is also the impact from currency developments for countries that are not in Eurozone. This can be really having quite some impact when the local currencies are volatile versus hard currencies. Then you have the cost containment, so clawbacks, compulsory price decreases. You have maybe the obligation to reduce the price whenever a product is expanding therapeutic indication. So all of this is present in majority of countries. And on top also comes tendering, actually. A lot of European countries do apply national or regional procurement in order to purchase plasma-derived products. And this has also an impact on the price sustainability, because these tenders are typically price-driven. So price is the most important factor for the manufacturer to secure either the whole tender volume or significant chunk of that tender volume. And that is where we would strive more for value-based type of contracts, where differences between products are more acknowledged than just the price. I agree that there are improvements visible because countries are exempting manufacturers from clawbacks, most notably, or they do not practice the price referencing each year. However, there is still a lot of room for improvement, and I want to stress here that we are speaking about a very specific group of products here. These are products that oftentimes do not have recombinant alternative in some disease areas. They might be life-saving for some patient populations, and these products do not have patent cliff. So it means that the life of these products in the market is much longer than for traditional pharmaceuticals that typically lose patent rights after, let's say, 10 or 12 years or whatever you have, and are replaced by generic substitution, right? Here we are talking about products that have been on the market maybe for 50 years. So it's really important that there is a consideration for pricing sustainability of those products.
Thank you. Thank you for this exhaustive answer. I think it really illuminates all those pressures and forces that are being exerted on the PDMP at large. And I think this is also a good moment because you mentioned there are only 2 countries that use value-based pricing without any IRP or ERP, being Sweden and the UK. That does not mean all is good in those countries. That doesn't mean that these countries have the most equitable access. But I actually wanted to maybe ask Jakub Dvořáček, the Deputy Minister of Czech Republic of Czechia, to maybe illuminate the situation in Czechia, because we may have some old data here claiming that Czechia does use some sort of clawback, does use some sort of ERP, but I know Czechia has been doing a lot to really move in this value-based direction, and how does that apply to PDMPs? We'll get to more detail later, but maybe just this aspect.
You know, Tomasz, what comes to my mind, it's a wonderful, colorful map, yeah? It really gives you, so many different ways, how the patients get, to the treatment around the Europe, yeah. And it's at the same time, it's just showing, the mess, yeah, which is, in all those systems implemented around the Europe. And behind that, you have a patient, yeah, waiting for the access. And yeah, it's also on the slides that you showed, and you're going to show how it's different, yeah, between the member states, and how big is the difference, in access of patients. And yeah, the question is, if we should come, with some kind of out-of-box step to move it forward, this discussion, to maybe to really make the access more, let's say, balanced for all patients around. And yeah, I mean, it's the nice tool is coming. So let's think, about the tools, which the Critical Medicine Act is going to give us in coming months, coming years. Of course, I believe for the industry it will be a little bit difficult, at the beginning, and I'm not telling, that this should be done, immediately to everything. But if you will be able to really work with the value-based discussion, but also to set up, the good conditions, for those patients who respond, who doesn't respond, and also to based on those joint contracts to set up, the conditions how to collect the data to get the good outcomes. Because we are also talking about how we are able to collect and then evaluate what comes out from those from those registers and so on. And yeah, I mean there are 3 nice tools coming in Critical Medicine Act. And luckily, or I don't know if it's luckily, from the perspective of producers, but PDMPs are very often the part of the critical medicine list. So all 3 tools, which are, let's say, mentioned in the Critical Medicine Act. So it's the cross-border procurement or the joint procurement, but also this procurement on behalf of member states. You can use it. Yeah, it fits to the pharmaceutical of common interest because it's essential. It's definitely important for the patient. So let's think how we can in the future make this access different, and maybe then it will be much more easy for patients to get to the treatment.
So, thank you so much. both for the comprehensive answer, but also what you intimated at the very beginning, that if you look at Europe, it's very colorful, this map, and it's colorful because it's a mess, because it is so heterogeneous. So there's clearly no way that there's any universal stance, any universal treatment, any universal solution, and that really creates a very, very inequitable environment for within the industry itself. And I think the picture is equally complicated when it comes to one factor that is being potentially part of the Critical Medicines Act and many others that are being considered, which is stockpiling requirements for PDMPs. As I mentioned at the very beginning, the huge risk within the PDMP value chain is that it is very fragile. So any disturbance at any level, collection, fractionation, delivery to the patients, reimbursement, any of that disturbance can really have a tremendously negative impact. And you can only imagine that if all countries in Europe required significant stock to be always stockpiled, always inactive, not treating patients with it because it's just sitting there waiting, that will take away so much product from the market that is already suffering shortages, that is already asking for significant increases in production. Again, this slide is not here to say that countries are wrong, but rather to showcase that there are countries that do not stockpile or have exempted PDMPs from stockpiling, but put them, for instance, on a non-export list. So there are many measures that are being used. And again, just to be very, very clear, there are only some countries that stockpile in the traditional format. For instance, Finland, which is quite a significant amount that they require for immunoglobulins to be stockpiled. There are other countries that require not so much the physical stockpiling, but rather a guarantee from a producer, from a supplier, that the product will always be available no matter what crisis situation. For instance, Czech is one of those. And of course, again, the heterogeneity of the picture is the problem here, and we may need to seek more universal solutions at a European level. And the very, very final picture, and I will also ask Tobias to maybe comment on it, is the picture of reimbursement itself. So we said cost containment, clawback, pricing issues with stockpiling, but ultimately we're talking about equitable access for patients. So what for patients matters most is whether or not the product is accessible and affordable within their country. And reimbursement is one of the steps towards it. So you can again see quite a heterogeneous picture. There are countries that reimburse even over 20 indications for immunoglobulins, meaning they reimburse both in and off-label based on the EMA SMPC. But there are also countries that reimburse very few indications for immunoglobulins. Clearly, this cannot be scientifically true for both. We are trying to make sure that the reimbursement, the access for the patients is equal everywhere. And this reimbursement also, the fact that we are reimbursing a lot of indications, again, does not guarantee access. It is only the first gateway. There's a country like Poland, we are now in a beautiful city of Warsaw, that does reimburse a significant number of indications, in fact comparable to Germany, which is not what we are used to, seeing the East-West division. But the actual access, the actual utilization, the use of immunoglobulins is 10 times lower per capita in Poland, which means reimbursement, yes, but access in reality, not so much, the appropriateness of the use. And I wanted to comment because we are talking about clawbacks, we are talking about many other aspects that can potentially be dealt with from a pan-European perspective. But of course, reimbursement is solely within the power of each jurisdiction alone. And I wanted maybe, Tobias, you can comment on how that interplay between pan-European versus local versus sub-local really plays, especially from a lawyer's perspective. You have the legal insight into this issue.
Yeah, thank you very much, Tomek. I mean, this is like a mixture of both, as you already said. Perhaps starting with a general remark, this all goes back to this competence article in the Treaty of the European Union, Article 168. And as we already talked about the SOHO regulation yesterday, this is quite an exception within this article. So there is expressly provided that the European Union has the competence to provide most of the regulations in this field. Whereas in most of the other healthcare and life sciences regions, the national member states still have the exclusive competences. And this relates without exception to these reimbursement questions, as well as to a certain extent at least, with regard to the stockpiling regulations. And so this is why we see this mostly colorful landscape here. And as you said, that Germany is kind of a showcase example for high-level reimbursement. This, of course, if you have a deeper look, has also its countersides. And it is correct that, in principle, you have reimbursement with the bringing on the market for all on-label use prescribed medicines in Germany. But then the devil lies in the detail, as said, and probably we come later to this, but this as a starter introduction so far from here.
Lovely. Thank you so much, because that's an important distinctions that you've made there that are not often understood. Very often we are complaining about the inequitable access, but in fact that inequity stems very often from national level policies, not pan-European ones. I think these slides that I'm showing here are of course part of the research that is ongoing. So look out there will be publications based on those with the recommendations that hopefully will be consensus driven from multi-stakeholders. So we have a multi-stakeholder panel. All of you will need to contribute to those papers one way or another from the perspective of a patient, perspective of a policymaker, perspective of a clinician. But I would like to return to the original point that I made as we opened this session. The word equity. And of course the word equity in its very core has the patient need. Meaning we can only supply equitable access if we understand the patient need or patient unmet need. EMA has gone very far in including patients in its risk-benefit analysis for all the new indications, for all the new medicines. But that's not necessarily true across the board in Europe. And luckily today we have a patient and a patient representative, patient advocate, patient educator with us, Adrian Goretzki. And speaking of equity and inequity, beyond those formal measures, of course, sources of inequity also occur on the whole patient pathway. Screening, diagnosis, treatment, availability, accessibility, affordability of the treatment, and so on and so forth. It's a very intricate interplay of what we are showing here and what patients actually experience on a daily basis. If you could comment on that equitable aspect or inequitable aspect, what are those real barriers, not only in Poland that you know of, but you are working internationally, so you are very much aware of those issues elsewhere?
Yes, thank you so much. First of all, there are, say, two perspectives, because having the perspective of just a patient, it's crucial to have an access to treatment. If being a diagnosed patient, being an aware patient, it's always about access to treatment. This is the most crucial thing here. Of course, there are some additional ones like the quality of the treatment, quality of the life, because of the treatment, burden of treatment, all of things related to treatment and further life management. But when it comes from the perspective of somebody with a bit broader horizon, it's also about those all things which comes before treatment, so public awareness, GP's awareness, diagnostics options, newborn screenings programs, transition care also when moving from adulthood, from childhood to adulthood. Sadly not that way. Those are things which contributes to this, and perhaps we could have a separate congress regarding what equity is and what is not. But from a perspective of a patient who is diagnosed, and I believe that usually we have this perspective, it's mostly about an access to the therapy which is accessible, which is not endangered. This is why I need to just have a one-side comment regarding stockpiling. I mean, to maybe defend our policymakers a bit, Poland has in fact stockpiling regulations because historically we're the first to be cut from various medicines in times of shortages. But of course this does not mean necessarily that you need to have it as it is. But regarding equity, from our perspective, also as patients with PIDs, I believe that other patient representatives here on the Congress can say that we need accessible and safe therapies.
Thank you so much, Adrian. And I'm sure there cannot be a one-size-fits-all blanket approach. When you spoke about stockpiling and you're saying you're defending national policies to do stockpiling, I think that also speaks of the motivation of the policymakers, right? The motivation maybe I want to ensure access for my patients, that's why I'm stockpiling. In effect, it may be short-sighted in terms of its actual impact down the line, but the motivation is probably valuable.
Well, I am not defending those policymakers and the reason why we were first always to cut, and our healthcare spending per capita is absolute disaster. But yes, this is why it was imposed.
And I think that very, very smoothly moves us to Anna Kostera-Pruszczyk, who has not only Polish perspective as a leading clinician, but also a pan-European perspective, both from the PNS, Peripheral Nerve Society, but also a European reference network. Perhaps you could also comment from a clinician perspective. We are talking a lot about equity today, but from a clinician perspective, there are potentially a lot of barriers to optimal treatment for the patients. Maybe you can give us some insight, because we often talk about the big formal legal frameworks, and we're not always looking at the day-to-day struggles, not only of the patients, but also the clinicians.
Thank you, Tomek. Of course, looking from the perspective of the clinician, I'm a neurologist. I treat pediatric and adult patients, neuromuscular patients, and my center in Warsaw is also a member of the European Reference Network, meaning that we collaborate with over 80 sites, leading sites from other European countries, and we often share the same concerns regarding equity in terms of access to diagnosis and treatment. Of course, having the safe supply is the very first thing that our patients need. This makes also us feel secure. We had a very hard lesson during COVID, then we had to prioritize some patients. This is not the best word in medicine. We really like to treat everybody as they should be treated, but we had to prioritize patients with indications where HGs cannot be substituted with anything else. They are the only option. And also for pediatric patients or patients with acute indications. We had to seek alternatives for chronic patients, looking for some immunosuppressants, for instance, that would allow us to lower the dose. And this is not just for Poland. It happened across the world, also in European countries, also in the US. We are back to the safer times, I believe, for our patients. And for some reasons, I really view our Polish perspective as quite comfortable, because this reimbursement frame really reiterates what is set as a threshold for the patients who really do need access to immunoglobulins, both IV and sub-Q. Unfortunately, our overall consumption is not as high as we would expect, meaning that this bar could be lowered, probably. And this is one thing that we would probably like to work on discussing with the payers. But also, we have a certain legal way of treatment with IV products, meaning they are administered in hospital. And I really think that improving access to sub-Q, whenever it is indicated medically, but also working on some solutions that will free the patients from frequent hospital visits. This would probably help the patients, but also us physicians. Some of the patients would choose alternative therapies just not to travel to hospital every month. With sub-Q treatment, they would be free from us. They would visit us just to check whether we should continue or not. So there are several solutions that really have to be faced from the physicians and patient perspective, and I would really like that the payers look at the quality of life, not only as the effectiveness of treatment, but also as the quality of life related to the mode of treatment, because it's really something that in chronic diseases can really change the view.
Yeah. No, I mean, that's a tremendous perspective, and there are a few extremely important elements here, of course. You mentioned prioritization. I think we all agree that in the ideal world, we would not need to prioritize patients, because we need to service each patient's equitable access. You mentioned eligibility. I think that's another way that it's not reflected on the slides that we showed you, but some countries actually control the flow of PDMPs by having very restrictive eligibility criteria, meaning again affecting equity. It's leaving out whole patient subpopulations without treatment or with suboptimal treatment, as you say, with either just immunosuppressants or just corticosteroids. And finally, you talked about equity from this rather broader perspective of actually having all patients involved in that process. And I think between what Adrian said and what you said, equity being listening to the patients, understanding the need, making sure that we do not have those barriers. That sort of leads me more to Jakub, to you, because I think from those two perspectives, it's very interesting because Czech Republic, I always say that, is probably the ideal, not ideal, fine, nothing's ideal, but the optimal way in which a system involves patients in policy making, but also in decisions for reimbursement. So that's one thing that I think links to the equity very clearly. And Anna also mentioned quality of life, broader perspective when bringing reimbursement. That's another aspect I think the Czech system is remarkable with. Having this multi-criteria decision analysis within its HTA, really looking at very broad societal perspective, even looking down to what Anya said, practicality, the difference between subcut versus IV. That is already a value assessment within a system like Czech Republic. If you can comment on those two aspects, patient involvement, engagement, and of course the system by which you take into consideration value rather than just volume.
Thank you, Tomasz. I think I mean, Czech Republic is definitely not the ideal country, but I believe, that we try quite hard to manage the needs of the patient. And as you know, I mean, we have a patient council where all the patient organizations are involved. And if I take the examples from the last few months, we finished it, or we are now finalizing the new approach, for example, towards the Alzheimer's disease. We have a new registered product. Why I'm talking about it? It's always about the discussion between the medical scientific society, of course, but also the patient organizations which are involved in this field. And then it comes, with finally the discussion comes to the payers, yeah. And then you have a national approach, which gives you the chance, really in long-term perspective, how the access will look like. How you will identify the right patient in the right time, how you will open it, the capacities in the centers. And I'm talking about the Alzheimer because it's a first in class now, yeah. And you have to then build a totally brand new system, a new capacity to manage it. And of course, without the patient involvement, it's very difficult. So, I mean, that's what I believe, I mean, we are doing, quite well. And then it's also about the funding, yeah. And I think, this area is not the area which is really harming the system, yeah, with the cost. It's somehow manageable because it's also, let's say, covered, by the tenders, and so on. But again, if we see, how the access develops around Europe, when the new pharmaceuticals comes, and we see that it was one of your maps. It's not that the Czech Republic protecting the new molecules to come, but still you see, there's the limited number available. I think it was 15 or some of them available directly to patient. Why it is? It's a good question, because we are offering very free open system. Of course, we are referencing, but we are not setting up the maximum price, for those therapies. Yeah, they are because it's only the reimbursement, and then it's on the discussion between the company and the providers. Okay, there could be some caps on that level, but not national one. Yeah, so it's also about the willingness of the industry to come at the right time and to offer the products to the patient. So it's not always the systems pushing back the therapies. Yeah, it's also if the marketing authorization holders have the capacity to come through the evaluation, if they are coming with their applications to the national regulatory systems, to get this overview and good data to be evaluated.
Absolutely. I believe, Natalia, you had an urgent comment. If that's the case, please go ahead, because I think the discussion is getting quite complex and very multidimensional. I think also that means that once Natalia has managed to make her comment, please do raise your hands if there's an urgent question from the audience already at this stage. We don't have to wait until the very end, as I mentioned at the beginning. Over to you, Natalia, to add another perspective.
So actually, two comments here. I couldn't agree more with Professor Kostera-Pruszczyk about the involvement of quality of life aspects into evaluation of especially PDMPs. Within certain groups of plasma-derived medicinal products, there is a belief that there might be to some extent interchangeable, that they have very similar clinical effectiveness and so on. And I think that we need to probably rely more on patient-reported outcomes. We need to amplify the voice of patients in terms of what these products do, how these products help the patients have normal or near normal life, and we need to consider this in healthcare decision making by, for instance, providing a broad product choice, because it's not like this probably that patient A will stick only with one product type throughout their lifetime, but they might be changing the products as they change their lifestyle, right? And this is how we can also find synergies, including economic synergies for the healthcare system. And to the comment from Deputy Minister, I think this is great to hear that you have this in Czech Republic. The way I feel about this from my day-to-day experience working for a manufacturer is that most payers are not very willing to consider quality of life in decision making. Especially, I think the problem might also lie in the fact that plasma-derived products are considered old products. Like a lot of them are on the market since years, and this means that the attention of the payers is somewhere else. They focus more on those products that are new to the market. They need to put a lot of effort and resources into assessing these products. So it's a little bit hard to direct the attention of the payers to products like PDMPs, and then to amplify that patient voice and encourage the payers to make a consideration for quality of life of the patients.
Thank you so much, Natalia. This is incredibly valuable insight and perspective. That's absolutely right. And when you mentioned, our products are old, but that does not mean they can ever be treated as generics. And yet, in some jurisdictions, they are treated almost on par with generics or almost on par with biosimilars. So it's not really, it's not at all the same category. And you've also mentioned novel treatments, how policies and policymakers and payers are focused on novel treatments. I think that's something very important that I would like to ask Anna Kostera-Pruszczyk to illuminate what's coming in the next 5 years, because we know that PDMPs are not the only solutions for many of the patients, and there's a lot coming that's going to be very disruptive, very novel. But before we do that, we also have two lawyers here, Tobias and Adrian, and maybe you could add a comment on what both Natalia and Jakub said before we move to Anna. Adrian, I know you've worked extensively on understanding patient involvement in decision-making, patient involvement in policy-making, patient involvement in reimbursement. And Tobias, you have this very deep insight about Germany, where it doesn't really happen. The patients are not very much involved in the decision-making. So maybe we could provide those comments from a legal or practical framework perspectives.
Yeah, thank you. In principle, you're right, but unfortunately, I must share the opinion of Natalia, because we already had this starting point that prima facie in Germany, the reimbursement system seems to be very good, but this goes 15 years back, where the German legislator already decided for the first time that they need to lower the drug prices, and so they introduced two new laws, and the first one was the so-called AMNOG, so the reformation of the medicinal products market. But this system relates mainly to drugs with new active substances. So this is not mainly applying to PDMPs in Germany. And they instead have or are subject to very strict rebate system, which also provides a price moratorium for medicines with known active substances, even if they are brought to the market with new in new indications. So, and that is the reason why, because this was also introduced already in 2009 and is still applicable until at least the end of 2026. So there is several constitutional complaints ongoing on this price moratorium, but at the moment it is still applicable for PDMPs that are not subject to the AMNOG procedure. And this is a real burden for most of the PDMPs, because this, as said, also applies to new indications. There is a small exception that was introduced 2 years ago for immunoglobulins, but this is limited to immunoglobulins that entered to the market from 2019 ongoing. So as most of the PDMPs are authorized before, it does not help so much here.
That's a great insight into again, those pressures under which the PDMP ecosystem is, and especially within the legal framework. Also, I think important, and we'll pick up on this later within AMNOG, is that the German policymakers, the German payers, really look at very high quality data, demand very high quality data, and yet we are within an ecosystem where that data may not be very high quality. It may be a series of case studies, because we are talking about very rare, sometimes, conditions. So I'm sure we'll pick up on that. But before we do that, Adrian, one more comment from the patient and legal perspective on this, how the system works.
Yes, indeed. My team and I, we recently have reviewed many healthcare policies of the European countries. And when it comes to general framework, I mean the framework for all diseases, not just for those treated with PDMPs, I would say that it was perhaps the funniest example is from Austria, where in the pricing and reimbursement committee there are there are pharmacists, there are physicians, not necessarily involved with the disease, but there is also a member of the employers association, a member of trade unions, but there is no patient. So this is the system, which is very complicated, and still they ask everybody except the patient about it. On the other hand, on the other scale, there is the other part of the scale, there is Czech Republic, of course, with a very good system regarding reimbursement, the orphan drugs, for also drugs being used in rare diseases. Also, PDMPs can be classified as those. So where there is a real participation of patients on the several aspects on the proceeding, also in the beginning, but also when it comes to the voting. Voting rights, one thing is that this is very important from the legal point of view, and from the interest also of the payer, is that the patients with a certain disease cannot vote in their case, their specific disease. Yes, so this is a check and balance mechanism, which prevents from always voting yes. So when it comes to general framework, it doesn't look very good in Europe. Everywhere in the world doesn't really looks very good when it comes to patient participation. So this is why we are keep talking with Tomasz that the Czech Republic is almost ideal system
in this aspect.
And there's also they have a definition of patient organization, which is not very common, and a register of verified organizations. Many things to follow. But when it comes to PDMPs, it's also that it's not very common to ask patient organizations for their statement regarding treatment. This is like, of course, we are in countries where there are tenders, so patients have no influence on who is going to be selected in this tender. So I believe that in our area, which is a special area of medicines which are made from human plasma, patients have no influence on on anything, and perhaps they even should have more influence on questions of safety, of their safety, donor safety. Maybe not the design of the system, of course, but in general, we lack. I was a leader of the Polish Association for Patients with Immune Deficiencies for 10 years, and we really fought very hard to have anything to say regarding ourselves, our fate, us with the disease which is going to be treated lifelong. We have no other option than immunoglobulins. It was hard to start a dialogue with the ministry, so I'm very happy that it's changed, but also I'm very happy that it changed in Europe with an example of Minister Dvořáček and the Czech system.
Thank you so much for this perspective. I think linking it to, lots of rare diseases with very low data quality sometimes, it's not just the legal and systematic involvement of patients that matters, it's the pragmatic aspect of it. Who else is going to give us more of a feedback on patient-reported outcomes, patient experience, patient preference, than the patients themselves? So even in systems without the legal framework, that needs to be known, specific to rare diseases. I want to stop very briefly here to look if there are any questions from the audience, because we've covered quite a lot of ground, and we are going to have a little bit of a step change and move more to the future, with Anya maybe explaining to us what's coming, what is the expectations for the future. Unfortunately, the lights are very bright, so I don't see anyone's hand being raised, so maybe just, please.
Thank you, Leni from Warsaw, from IPFA. Thank you for a very good discussion, and this is a very interesting topic, and it's the first time we really see the difference of the European countries so clearly, so good work on that. I'm really happy to hear the comment from you, Natalia, how PDMPs are really old products, and they don't fall into any suitable segment anymore for our reimbursement or pricing bodies in the countries. And I was thinking, are there any other products, pharmaceuticals, similar to PDMPs? Or is it really so that we are the only ones which are not losing, like the new products that come and lose their patents and become generics? Is PDMP really alone, or can we align with somebody or some other group? I don't have myself knowledge of that, but that might help in the long term. But very good comment. And another is that it's really all the new mechanisms that are being introduced in countries. They are for new products. They are never for PDMPs which have been there forever. And you can't get them into that system anymore when they are already there. It's a really tough situation for our field, I would say.
Absolutely. That's a great comment, and maybe Natalia, do you have anything to add to this? Because I think this really has huge consequences along the line. We've already seen that, for instance, because they are old products, they are treated on par with generics in pricing, rather than having value-based pricing applied to them, and so on and so forth.
And also, when I try to empathize with the perspective of the payer, I can understand where they are coming from, because they need also simplifications for decision making. So this is why they probably so eagerly push PDMPs into the same box as generics or biosimilars, but these products are not the same. I cannot answer the first part of your question. I don't have knowledge there. I cannot tell whether there is any other group of products that has similar complexity as PDMPs. I want to say I don't think so, but I don't know. That's the right answer. I think that we simply need to educate much more and hopefully create a brand new box, the way there is a box for orphan drugs, and everyone knows what an orphan drug means, be that a policymaker or payer, and there is recognition for the value that these drugs bring. I think we need very similar recognition for our old, good PDMPs.
So,
thank you so much.
I have a comment to augment Leni's comment, and it's mostly directed to Mr. Dvořáček, in relation to the Czech Republic. It is interesting to hear about this progressive framework in relation to engagement with patients, especially for the new drugs. But we come back to PDMPs. The Czech Republic is often described accurately as one of the world's largest producers of plasma for fractionation. At the same time, the Czech Republic's usage of plasma-derived medicinal products is very low. If we look at immunoglobulin, it is clear that by any standard, patients in the Czech Republic are not being treated adequately. And I just wondered how, this issue can be addressed. Because here is a community which is generating all this plasma, and yet the community doesn't seem to be benefiting from it.
Thank you so much. That's a super important question of solidarity and fairness.
Thank you for this question, or let's say more comment and question. It's interesting. You are absolutely right, because we are not blocking any the plasma-based products to come to the market. It's not that there is it's mainly on the medical professionals, how they used to work with them, how they applied this treatment in accordance with the guidelines and so on. But there is no, let's say, restrictions. There are no limitations. It's definitely based on their decision how to treat the patient. Yeah. What is behind and why it is not widely used, it's difficult to say. It's definitely not about the caps or, let's say, any ceilings which are set by the government or by the payer funds. Because normally, those products, or maybe the only ceilings could be done based on the hospital tender, yeah. But it's fragmented. It's not something that generally blocks the access, yeah. And you're absolutely right. And if you compare the willingness to donate and how this is still increasing, the last year, 2024, it was the best ever. It was more than 1.3 million liters, from 10 million population. It's really excessive. It's good, definitely. We will have to also see, let's say, more of those products, to be available on the market. The question is, why some of the marketing authorization holders doesn't come with their, let's say, proposals. We had a number of discussions. Sometimes it materialized, sometimes not. But as I said, there are no restrictions for the patients to get to this kind of treatment.
Mm-hmm. That's a very important perspective that those slides were not portraying. Because, yes, indeed, there are many countries where there are no real restrictions, and yet the usage may not be appropriate. And I'm using the word appropriate very consciously here, because sometimes it is about appropriateness of use and awareness of many of the clinicians where and when can they use it. I urge you all maybe to look at a publication that came out of Poland, where actually Kostera-Pruszczyk was very much involved, describing, I think, over 18 different indications on how IgGs, immunoglobulins, ought to be used, but may currently not be used. So it may be at that level. And I think, unless there are other questions, I think this is a perfect segue to the question that I had for Kostera-Pruszczyk. We're talking about the actual use currently with immunoglobulins or with other PDMPs. But the landscape is rapidly changing. It's not just about the use of PDMPs, but it's going to be about the use of new biologics, FcRn, C2, it's going to be potentially gene therapies coming to the market. We already know that they exist in myasthenia gravis, they are about to exist in CIDP. So it's getting very complex. We haven't quite sorted out the basics with an old product, and yet we are going to get a lot of new complexities in therapeutic paradigms. Maybe I think everyone's very keen to know what's coming and your perspective on it.
Well, this is an excellent question with no clear answer from me, but I will do my best. I think we should realize that the new biologics that are really coming to play in neurology, they are very promising agents. They have very nicely designed clinical trials with patient-reported outcome measures included as well. So, of course, a part of the analysis that is done for the reimbursement can be simple, but it's also only a part of the picture, because we are also aware that in the perfect world, the treatment that I choose for my patient should be based on the efficacy, safety, mode of action, the way treatment is administered, whether my patient accepts it or not, whether the patient can accommodate it into the daily living of him, her, or the family. In fact, we are bound by the reimbursement criteria, meaning that with the aging society of Europe and the increased burden of all healthcares, we are really discussing also within our international or national scientific societies how to choose the best treatment for the patients. And I really think that even if we finally have as many as our rheumatology colleagues, PDMPs will be needed for neurology, even in higher extent than we use them now. Because all of the clinical trials that have successfully published the results show that it's usually like 60-65% of the patients that meet the clinically meaningful improvement, that meet the primary outcome, meaning that we will probably have to look harder for good biomarkers to optimize the treatment, to make it more personalized. But my worry is that the reimbursement criteria will be really the limiting factor, not what we think about novel biologics. We also should remember, okay, this is maybe not the best place to say, I do not know how really IVIGs act for many of the neurological diseases. I mean, the mode of action is very complex. The biologics, they are very targeted, which is great for some situations, but maybe not so great for other patients. So this will be probably either or, and for some new biologics, polytherapy that will raise the patient to higher functional level or save from the progression of disease. So I really hope we can use all and everything without limitations, but time will tell.
I'm really glad you mentioned quite a few things that are actually of tremendous importance and novel insights for all of us, but you also referenced neuromodulation. Yeah, in many cases we don't know what's really happening. We know the basic principle, but we don't know truly what happens for each individual patient with a particular biomarker. And now, of course, with the multiple treatments potentially, as I said, with polytherapy added on top, the picture, clinical picture, the etiology picture will be even more complex. And I think it will also be another challenge for the policymakers and reimbursement bodies. As we all know, I'm not sure whether we all know, but we probably do, for years now, the issue with polytherapy or combination therapies has been of tremendous importance for many policymakers. In oncology, now majority of trials are in combination therapies, but many countries refuse them because they don't know how to price two different molecules that are suddenly combined for the treatment, and it's probably going to be as problematic for PDMPs. And I think another comment that I want to make sure that we accentuate, it's super important what you said, that the novel treatments as they come, they do not necessarily mean less IVIG as SCIG will be needed. It might actually mean that we need more of it for those poly treatments rather than less. So it's not hope that this is going to replace it. It's a hope it's going to just bring much higher efficacy and much higher personalization of treatment.
If I may just add one thing, as I said, the COVID times were terrible for the patients and for us, and I really think that with plasma-derived products, we need something that will be independent from the donor pool, so there will be probably, this is my thought, a good balance between access to different therapies that will be really well tailored to the pathogenesis of different diseases, and what the patients can gain from it.
Thank you so much. And actually, maybe somewhat provocatively, we have spoken over the past 2 days of many different pan-European legislation, but I think one that we haven't really brought to light, and I think it's quite an important one, is the cross-border care legislation that allows, especially for very high-cost therapies, and this is what we are expecting in neurology to come through with those polyneuropathies, for patients to be treated anywhere in Europe. Therefore, bridging that gap that we saw with reimbursement, bridging that gap that we saw, for instance, with capacity of the system, with the existence of the right reference centers, right clinicians. Let's start maybe with a proper policymaker. Do you see any role of this cross-border care, and how can we really maximize its potential for those treatments? Maybe let's start with Tobias. Do you want to start? From the legal perspective, maybe illuminating how that legislation and regulation actually works in practice.
Yeah, of course. I mean, of course we saw many improvements in the last years in this regard, but in my view, or in my impression from a legal point of view, it's of course limited to more or less single cases, and probably, but that's probably more to Jakub to fundamentally consider this. It should probably not the aim to be the aim to set up a system that is based on cross-border reimbursement system. So I'm more here with the comments that we see, and this is something we see in the whole discussion today, that there's a gap for orphan diseases or orphan drugs between the incentives on the marketing authorization procedure and the reimbursement systems of the national member states. Because if it's not a new substance, then there is no real incentive for these products. We see this also for other cases than for PDMPs in Germany in the reimbursement procedures. And by the way, there is another regulation that we did not mention so far, also not yesterday, is the European Health Technology Assessment Regulation. That also will come into force for orphan drugs in 2028. But this also only applies to medicines with new active substances. So this would be more my approach to change this, to find new solutions there.
No, certainly.
So if I can build it, oh, sorry.
No, please go, yeah, we'll get Adrian definitely to comment.
Again, the example, yeah, which I think, it's showing, where we are and what needs to be done. We had a patient, the most expensive drug, I will not name it, and one center in Europe, it was Germany, offers the price. Then we had the offer, from France, and the difference was 1.2 million euro. Yeah, it was the most expensive drug. Yeah, this 4 million drug. Yeah, but still, you see the difference is really huge. So if you do the care case by case, you usually pay a fortune. And it's so difficult to really, quickly then allocate the patient to the right center and so on. So we are now, it's already done, it's in the Senate, another change of the Czech legislation on the health insurance. We are allowing the payers to create like a long framework contracts with providers around Europe. It's also focus also on the near of the border care, but it's also allowed the payers to manage the contract, which really reserve the capacity and also like a long-term relation between those payers, and that care which needs to be managed somewhere else. And I think this is the way, because we don't have to build so many different new centers around the countries if they are existing one, especially with the rare disease. Yeah, but also for other diseases which are maybe not so broad. This could be a good model. If there is a capacity, there's no need to build another capacity locally. And if it is really, we're always talking about how the care should be centralized. Yeah, what is the best for the patient? Is it good to have a care behind the door, to be able to walk to the hospital, or is better to have like special care concentrated in the center where they can treat the number of similar patients with a great experience? My perspective, I would definitely choose for the one with the best experience, yeah, and with most experience, with the implementation. And I believe, this needs to be implemented not just locally, state by state, but we have to use this experience and capacity on the European level. And it's just, how you allowed, your payers, your mutual funds to work with the money and to how they can create these framework contracts to implement this kind of care.
Another fantastic comment, it sort of brings to mind that we are also not shifting just in terms of new therapies, but how they are delivered, which is what you're referring to, in which setting they are delivered. Interestingly, in Austria, there's a dictum, digital before inpatient, inpatient before outpatient. Outpatient before inpatient. So meaning the inpatient, the hospital-based care is really the last resort, or trying to rejig the system in such a way that hospital becomes the last resort. But before we get too much complexity into this issue, I know, Adrian, you wanted to comment also on the whole discussion that's been happening thus far.
Yes, regarding cross-border healthcare, in fact, because I just want to make sure that the people here understand that, because sometimes I hear also on many patient conferences that, wow, we should use cross-border healthcare. No, in fact, it's a mechanism which inception is, its inception is because to optimize costs and to make the care the best possible, of course, but it's not made to be a EU alternative budget for treating diseases. You can just move patients, if everyone agrees, from country to country with better care, but it's not that there is separate budget for it, because there is no separate budget for this. And we have been using it, I was using it when I was a single disease patient advocate back in the years for patients with SCID, so rare PAD for bone marrow transplant or gene therapy, mostly for gene therapy. But it's very rarely used, so this is not a topic for us at the moment, totally, I believe. Because it's not the thing we can think, as Tobias said, about the centralized, centralized healthcare system, but for now it's the exclusive competence of the member state. So when it comes to the cross-border healthcare, this is my comment. And well, if I have any others regarding this discussion, I think that rather still we are a union. At least regarding European Union, I know that many of you is outside of the EU, but we live somehow in a bubble here. So regarding EU legislation and situation in the EU, we should rather put pressure to do the best possible, to make use of the best possible solutions in member state, and this is also a role of the European Commission, and this was said by Stefan earlier, to promote it and to see, to present those solutions to the rest and recommend it, but we are not in power here to change the treaties of the European Union and to, provide healthcare for everyone under the auspices of the EU. So what we can do is to promote it, but also having in mind the situation of each specific country, as it was mentioned by me, and before that we had a discussion with Professor Kostera-Pruszczyk. We have a scandalous low per capita spending for healthcare in Poland, according even to Eastern Europe. So with this, we cannot do more than is physically possible with such a budget. So this is why I think we should, first of all, before dreaming of a single healthcare system or federalization, work on the policies in specific countries. I know that it's hard, because there are 27 different countries, but for now is the only option for us.
I think, Anna, you had an additional comment to
Yes, European
clarify.
Reference Network was created almost 10 years ago to avoid the transborder care, because the brilliant idea was that the knowledge should travel, the patient can be well diagnosed and treated at home. And I think this is the idea that really needs to be expanded. We are working on having more rare disease expert centers here in Poland. We as ERN Center participate in some international consultations, mostly for diagnosis of very difficult patients, but also for shared decision making for treatment of patients who do not respond well to treatment. But I think that very important part of ERN and what we are trying to do, collaborating between different centers, is shared experience. Adrian Goretzki mentioned SCID, and we are now in the process of introducing SCID into our newborn screening program, which is excellent. This is really one of the best, if not the best, tool of public health, diagnosing people before the disease takes whatever cannot be given back to the patient. So I really think that looking at the best practices that have been already implemented in different countries and shared them is very important, because it will save a lot of money that can be wasted along the way, with the long journey of the patient, with the diagnostic odyssey and so on. And these resources can be moved to better treatments, to this equity for treatment, and I really believe in education, in awareness, in doing all these basic activities.
Absolutely. And thank you so much for bringing us back to the core topic of the discussion, the equity and how we can ensure it. And you're absolutely right. Sometimes it is the wastage within the system, it is the inaccuracy, such as with the lack of screening, that costs us so much more than the treatment itself, and costs the patient so much more in the end result. I know that we are painfully short of time, but I really wanted to make sure that we stop here very briefly and again open the floor to any questions. I know that it's been a very intricate discussion thus far, so please feel free to comment or ask questions to specific panelists or to all panelists. I can't see anyone. Are there any pressing questions or comments? Or maybe we've missed something. Okay, well, I'll return therefore to our excellent panel. Now that we have just a few minutes left, I think the discussion has really been quite extraordinary, because we have touched upon legal, philosophical issues such as equity, solidarity, fairness, and also extremely technical issues of the current state, but also what is coming in the future. I couldn't be more proud of our panel really bringing in some of the conclusions to the discussions thus far. Maybe not conclusions, but bringing in some of the perspectives that we round off many of the discussions that have been happening over the past 2 days. And in that spirit, I would love to ask each one of you, maybe in a couple of minutes, to summarize what's critical for you. What would you recommend we do specific to limiting the sources of inequity, promoting better inequity? How can we really move forward from now? Much has already been said, but maybe as a summary. I think, Natalia, we haven't heard from you for a little while. Why don't we start with the industry perspective? What can we do?
Sure. I think I already shared one recommendation that was about creating a specific category of drugs, a new category of drugs that would contain the PDMP group. I don't want to go into details, but the idea would be to create such a group and to ask for some different rules for these drugs. So less cost containment, no reference pricing, allow price increases where they are critical for price sustainability, so that there is still broad product choice on the market and patient access possible. So I think that would be one thing. The other thing my policy ask would be, or policy recommendation would be, linking to what the professor said before when it comes to, for instance, home care. If we look at immunoglobulin portfolio, there are different ways of drug delivery, right? Patients can be treated intravenously or subcutaneously. And across Europe, we still see that subcutaneous therapies are not really picking up as much as intravenous therapies have. This is because there are no policies that support that treatment and that really enable patient access to this therapies the way they enable patient access to intravenous formulations. A lot of manufacturers of these products, I believe, provide patient support programs in order to facilitate that patient access, because payers do not cover the cost of, for instance, pumps, ancillaries, tubing, or cover it only partially. So this is a clear, I would say, policy gap, and it would be great if we can breach that gap. I think inclusion of patient voice, amplification of that patient voice, bringing the patient to the table on equal level as other experts is critical. Looking into patient-reported outcomes, maybe, of course, with not as much attention as payers and decision makers look at efficacy endpoints, but at least have some solid consideration there for those type of data. That would be like my top 3 policy recommendations.
Thank you so much.
Thank you.
I'll just add a very tiny insight as to your recommendation actually already being applied in one country in the world, surprisingly, that's Saudi Arabia, that is looking to create PDMPs as a separate category and is looking to reevaluate all of them as if they were innovative. that potentially is a very weird place to benchmark, but if they got it right, if they get it right, why can't we follow the best practice? I think maybe, Tobias, if you can give your perspective and your recommendations.
Yes, of course. Yes, from my limited legal perspective, I would say what I see as well in national processes in my work for PPTA, Germany, for instance, but also for other industry association on a European level, to all the stakeholders, try to engage as early as possible in the legislative processes, because I have the impression that as well on a national level as well as on European level, the doors are wider open than some time ago in the institutions. And on the other hand, also keep discussions, conversations with the payers ongoing, because perhaps we get a more kind of individually based contract negotiation system for special treatments in the upcoming years. So that's perhaps another recommendation.
Thank you so much. And jumping from the legal frameworks, jumping from the important notion of uniqueness, maybe, Anna, we can return to you and again bring that all-important clinician perspective of potentially not only recommendations of what we must do, but potentially maybe something's already happening that is a great practice that we can maybe transfer. It's a transferable solution to our situation.
Well, this was not, it is not the answer to a question, it's just the experience that I have when I enter a room of the patients that are treated with IVIGs. These are happy people. We rescue them, and I really want to continue.
Thank you so much. That could be the last word, but we still... I should have been cleverer and asked you to comment as the very last, because that would have beautifully summarized the entire 2 days of IPPC. But I think we still have two people who we really need to hear from. The patient perspective, and of course the policymaker perspective, equally important in actual application of those solutions. I will normally always end up with the patient first, and then patient last in any discussion. But today I'll make one exception, for a very simple reason, because Jakub is bridging many of those multi-stakeholder perspectives, having been involved in European Critical Medicines Alliance, having been involved in the creation of the Czech system. So because of your very breadth of experience, I'll allow, for once, Adrian to comment now, and for you to summarize and comment as the very last one.
Thank you, Tomasz. I wasn't the first one in the discussion, I was the last one this time, so it failed twice. Speaking, well, frankly, of our area of medicine, from a perspective of a patient advocate and a patient myself, I would say collect, especially the Europeans, collect more plasma, no matter how you don't care as patients, what is the brand, or it's private or public, it needs to be safe, it needs to be accessible. So please do collect more plasma. Thank you.
And now the tough job of being the last speaker. Jakub, over to you.
Thank you. I mean, we'll be probably not able to collect it more in the Czech Republic. You know, 1.3 million per 10 million population is really quite a good result. But you know, my wish is really to finish the pharmaceutical package. And there is a lot of things, you know, which are also, you know, in favor of patient organizations. You mentioned here the topic of definition of the patient group. That's one of the topics, you know, which we are now finalizing, and it will really help to have the recognition of patient organization around Europe. It will help all the countries who doesn't have it. That, I believe, is very important. We didn't succeed with the regulation of advertisement, because the Czech Republic, jointly with Netherlands and a few more countries, we propose also to have, let's say, the more open space, you know, for patient groups to talk to their members also about the therapeutic innovation, things like that, to really manage the flow of those crucial information to patient. But it was probably, it will be not probably included in the final text. And there's a number of others, and we really need it, you know, as soon as possible to finish this material, to also ensure that not just the innovation, but also the rest of the pharmaceuticals will be hopefully more available, you know, for the patient. But what is my wish, you know, for coming time, to still be the most favorite nation as Europe for the pharmaceutical industry. Hopefully, and I know it's from your side, it's probably the opposite, but really wants to keep it, you know, the good prices for the European patient. And yeah, I mean, we have to also do a lot of steps, you know, to ensure that those prices will be confidential. It will allow the patients to get to the treatment where they need it, and we have to adjust it our systems, and we have to keep to adjusting all the time. You mentioned the combined product and so on, to keep the good sandbox system to allow the companies to discuss it, the offer, you know, for payer funds in those combinations. That's something, you know, what needs to be implemented everywhere around Europe. Maybe it will be much easier if you do it that in once, yeah, not step by step in 27. So yeah, that's from my side.
Much. I think we really had a holistic, multi-perspective recommendation. So I cannot thank you enough for bringing in both the substance, the recommendations, and the future outlook for PDMP patients or patients who can benefit from PDMPs. And that brings us to the conclusion. I believe we still have the very last conclusion of the entire BBC coming through. So thank you so much to the panel. You can slowly return to your seats. Unfortunately, the audience has missed the opportunity to ask any more questions, but with the last half hour of the day, I'm sure that our panelists are approachable.